It's always a pleasure to be with our dear professors. I will present not just an interesting case, but just a new scope for diagnosis of ischemic heart disease. The question here is myocardial deformation versus perfusion. Is straight imaging can be alternative to nuclear perfusion? Is this myth or reality?
Do you need an answer?
I'll proceed for this.
I can say no.
I'll proceed for the answer. Okay. We know that coronary heart disease is a leading global cause of morbidity and mortality, and any improvement in diagnosis can add to patients in our country is considered as a very high risk country of coronary heart disease. So diagnostic techniques of coronary heart disease, as we know, are functional diagnostic techniques or anatomical diagnostic techniques, and some trials try to add function anatomy as one-stop shop exam, but still not approved widely. However, echocardiography is usually considered as one of the best cardiac investigations, being cheap, non-invasive, widely available, bedside, radiation-free, highly informative. And using echocardiography for diagnosis and assessment of ischemic heart disease is usually a well-known option for every cardiologist, but it depends mainly on segmental wall motion abnormalities during rest study or even during stress-induced studies. However, usually operator-dependent, and there is significant inter-operator variability. So, what can deformation imaging add? Deformation imaging with speckle tracking may be a feasible technique, being more or less not operator dependent. And the display of global ingress strain is more or less like pulse eye mapping we are usually use in nuclear cardiology. So, on the other hand, we have myocardial SPECT. It's a well-established, non-invasive method for evaluation of coronary heart disease. So, let's see our cases. This case is 53 years old male patient, hypertensive, smoker, presenting with atypical chest pain. Pretest probability based on chronic coronary syndrome 90, based on chronic coronary syndrome 2019 was 17 with intermediate pretest probability. Perfusion here was normal, and if we used global ingress strain at rest, the global ingress strain was -22, and at stress, peak stress was -22.2, which is usually normal. So we have here a normal global ingress strain both at rest and at peak stress. So this is the coronary angiography confirms that the patient actually free of coronary heart disease. On the other hand, we have another female patient, 48 years old, hypertensive, diabetic, dyslipidemic, with positive family history of coronary heart disease, presenting with typical chest pain, pretest probability about 10%, and we have a positive perfusion study. So, on the other hand, the rest study was more or less normal, -18 or 19. On the other hand, at peak stress, the global ingress strain dropped significantly to -15.7. So, with these cases, we have our own. This is a coronary angiography, significant coronary disease in LED and LCX. So, with these cases, we have our own experience in Pennsylvania University. It's my MD thesis, two-dimensional speckle tracking during the between stress echocardiography versus myocardial perfusion imaging to diagnose patients with suspected coronary heart disease. Actually, the aim of work is to compare both tests, and the study design, it was a cross-sectional anatomical design, cross-sectional analytical design study was done in cardiology department, Pennsylvania University. Sample size was about 103 patients, and we included patients presenting with intermediate pretest probability more than 15% or low to intermediate pretest probability from 5 to 15, in addition to at least one risk factor like diabetes, hypertension, dyslipidemia, and so on. Exclusion criteria, we excluded patients that may have limitation affecting spectral tracking, like patients who have previous myocardial infarction or have a structural heart disease that may affect global longitudinal strain, or patients with suboptimal acoustic windows, and actually excluded patients with contraindicated to stress MPI and patients with left bundle branch block. Also, we excluded patients with intermediate coronary heart disease due to the non-availability of invasive physiological assessment by FFR, so we excluded also these patients. And we have this track. All patients has informed consent, clinical assessment, resting ECG, resting echo study. Then we compared SPECT, MPI versus invasive coronary angiography, then statistical analysis, and we have the results. I'll jump to the results of correlation. MPI SPECT defect size to the number of coronary heart disease, we have strong positive correlation with the number of coronary heart disease, diseased vessels. Global strain have strong negative correlation. Delta change have a strong negative correlation. Even global longitudinal strain at rest showed a weak negative correlation, but the negative correlation here was weak because all our patients were normal echocardiography resting study. We have all patients with normal echocardiography resting studies. However, if these patients have previous MI, the resting GLS even may be more correlated. Also, we have correlation with Duke treadmill rest score as moderate negative correlation, pretest probability, moderate positive correlation. Let's jump immediately to the summary of the results. SPECT versus global longitudinal strain. SPECT showed, as we said, strong positive correlation. Global longitudinal strain showed strong negative correlation, both at peak stress and the delta change between the rest and peak stress. Both showed strong negative correlations. Sensitivity was better for SPECT, absolutely. The sensitivity of SPECT was 90.6, while the sensitivity of global longitudinal strain was lower, still, however, significant, 78.1. Specificity was 92.9 for SPECT and 88.7 for global longitudinal strain. Area under the curve for SPECT was 0.92, while area under the curve for global longitudinal strain was 0.85. The cutoff point from the area under the curve for defect size about 4%, and the defect cutoff point for peak global longitudinal strain was minus 18.9, and the cutoff for delta change was minus 4%. This is a comprehensive ROC curve for all our research work in this study. Multiple results. I just summarized the results at the end. Limitation of the study was limited by the small sample size and exclusion of some type of patients, and we have no assessment for sensitivity and the specificity for each territory, because some territories are better, have better sensitivities in literature than other territories for this assessment. Also, we have no assessment for patients with intermediate coronary heart disease. Also, the test itself is limited by the inadequate views in some patients and inter-vendor variability between echo machines. Still, no approved vendor results global for all vendors, and the limited frame rates during examination of high heart rates with dobutamine stress echoes. However, the conclusion was both myocardial perfusion imaging SPECT and global longitudinal strain showed significant concordance with the result of invasive coronary angiography. Also, this confirms that SPECT is a valid alternative for coronary angiography, and this may encourage the use of global longitudinal strain in future work to assess patients with coronary heart disease. we published this research work recently in echocardiography, journal, and we have this is the second research work from our nuclear lab. We previously published another comparison between the myocardial respect and IFR for assessment of intermediate coronary artery lesions, and I have to thank you and thank our supervisors, Dr. Yasser Abdelhadi, Dr. Mustafa Muqaddam, Dr. Talat Saeed, who helped me in this work, and I have to thank our discussion board. In my MDCs, I wish to thank Dr. Islam Shawki specifically. He added a lot to this work during his discussion, and also Dr. Hisham Bosha, our professor, and thank you for this.